All right. Well, thank you everybody for coming and attending. We are very excited to have Dr. Dubois here to help introduce us to the CCC diabetes protocols. So I just very briefly, so the Community Care Collaborative, I'm standing in front of the camera, the Community Care Collaborative is endeavoring to put in place an integrated delivery system focused on the safety net population that we serve. And part of that is putting in place protocols for a number of different clinical conditions. And the first of these is in diabetes. And so I think they've had a very nice process of having a clinician-driven process for putting these protocols in place. And both Dr. Dubois and Dr. Peavy were able to participate in this protocol. So there was at least some perspective from folks that are seeing patients every day in it. And there's nobody better to introduce us to it and walk us through part of it than Dr. Dubois. Thank you.
Thanks for giving up your Tuesday evening, or Wednesday evening, I don't even know what day it is, for this very exciting topic. And it really is an exciting topic. And I think Rich and I were pretty pleased to see what came out of this group of experts. There were folks, there were obviously endocrinologists, family physicians, registered dietitians, certified diabetes educators. A lot of folks put their heads together to come up with this protocol. And so the purpose of tonight is to teach you sort of the highlights and to help make this useful. The thing I hate about complex algorithms when you see things is if they're so complex you can't follow if they're not user-friendly. So hopefully, just with some sort of tips and demonstrations, I'm doing this in a case-based way, so we'll walk through different cases and see how the protocol applies to people. Now, understand that our charge when we came up with this was to not to say what the usual care is or what we thought would be good care with the resources that we had available to us. Our charge when we came up with the diabetes protocol was to come up with the very best care that anybody who had any amount of money should have if they have diabetes. We weren't looking at a resource poor population. We were saying what is the best, because our patients deserve the best. We know that not everyone can afford every medication in the protocol. We understand that. We know that not everybody has access to a podiatrist. That's okay. We've got to start somewhere. And by writing this in the best possible way, the Community Care Collaborative is going to get us the resources, or at least do their very best to get us the resources that we don't have available to us now, like a foot doctor, okay? So as you see this, don't get nervous and say, oh, I can't do this because we don't have that resource. It's meant to get it for you. So what we're going to do is we're going to talk about this protocol tonight. We're going to review the standards of care. Now, your MAs are also going to be getting a training that's a little bit different. Yours is going to be heavy on the medicines. They're going to be hearing about ways they can support you. You know, every patient needs to have an eye exam. You don't need to order that. There can be a standing order for that. Every patient needs to have a wait at every visit. They can do that for you. So the things that your support folks can do for you, they're going to be trained how to do. So that hopefully that takes some of the easy protocol stuff off your plate, and others are doing it. We're going to talk about what the treatment goals are, what the medication algorithms are. We're going to talk about emergency protocols. What do you do if your patient is having a seizure from low blood sugar in the clinic? What do you do if your patient has a blood sugar that reads high on the meter and they're throwing up? You know, so that you know what to do in an emergency situation. And then at the end, if we have time, we'll be talking about how to do a comprehensive diabetic foot exam. Just very briefly, you know, we used to think about diabetes care taking place in the clinics, but really we know that's not where it should take place now. It really needs to take place all over the community. So some patients may do exercise at community centers, the YMCA. Some patients may have a researcher come to their house and do education. Or a visiting nurse. Some patients may go to diabetes education classes in the church, and we need to be studying in a thoughtful way the different interventions we do so that we can make the most of our resources. If diabetes classes in the clinic, you know, we've tried to do classes in this clinic several times and no one shows up. Well, that means that maybe they don't need to be happening here, maybe they need to be happening out there. So just as we think about diabetes care, I want you to think in that way. And also, you know, there's a picture, but the way that I did the slideshow, we couldn't insert it here, but there's a picture of your diabetes team, but since we don't have the picture, why don't we just have everybody stand up and introduce themselves? Because diabetes care doesn't just happen from you or me, it happens from the whole team now. And that's why even though this protocol is really ambitious, it's not just something you have to do, it's something everybody has to do. And the more you utilize your team members, the less is on your plate. So let's have the team stand up and introduce themselves. Liz, and we have Maria, we have a new nurse educator, right?
Yes.
So, has everyone met Maria? And Liz? Okay. So these people are available to you as well as your MAs, and they're going to be, you know, coming down to do some of the education as it happens. Okay. So when you see a patient with diabetes, we're going to start with page 13. This is actually the whole protocol. You have a copy. And we're going to hit the highlights on some of it. So page 13 is where the minimum practice recommendations, this is what your MAs and other support staff are going to be learning about. So they're going to be learning about, they have to take the family history, they have to do depression screening, they have to talk about smoking cessation, so they're going to be hitting the highlights on this page of things they need to do. Part of what you need to do when you see a patient is you need to do a complete history and physical the first time you see them. And when I do that, I'm going to tell you a little bit about how I do that. So the things that I'm interested in when I see a patient with diabetes is I want to know, oh, and by the way, we're talking about type 2 diabetes here, not pregnant patients, not type 1. We're talking protocol addresses adults with type 2 diabetes. So I'm interested in knowing how long have they had it, and how did it onset? You know, maybe they were found as a pre-diabetic and it just happened slowly over the years versus maybe they presented in a fulminant way with an 80-pound weight loss. We occasionally see that in ketoacidosis. So how did they present? What year did they present? And do they have complications? And when we're talking about complications from diabetes, they're vascular complications. If it's the small blood vessels, we talk about eyes, kidneys, feet, autonomic nervous system. Don't forget to ask about things like erectile dysfunction, bladder emptying, hypoglycemia, and awareness. That's the condition where you can't tell when your sugar's low. As well as macrovascular complications that have heart attacks, strokes, peripheral vascular disease, and then other depression. I was at the endocrine meetings in Chicago in June. One of the big topics we're talking about at endocrine meetings is non-alcoholic steatohepatitis. Diabetes, obesity is one of the leading causes, and it will surpass hepatitis C, especially as we get good treatments for hepatitis C, is the leading need for transplant and hepatocellular carcinoma. And so some of the drugs that we use to treat diabetes also treat NASH. And so we need to be aware of that. And some of the patients that are being identified as having cirrhosis have just a little bit of elevation. Their AST is 40, right? So you don't necessarily always see those big time elevations. But if you don't know to look for it, you might be missing that. And then dental disease. One of the things that Dana and Veronica back there, who are going around to different sites helping people institute this protocol, one of the things they observe that we forget to do is look in the mouth. And so we now have access to dental clinics that we can share with you guys, and I don't know if you have an updated thing, but basically, have you heard of these DSRIP funds, Delivery System Redesign Incentive projects. So they come with millions of dollars, right? We call them the DSRIP funds, but they come with millions of dollars attached, and that's how we get some of the new resources we need. So our patients haven't been able to get dental unless they happen to be able to go to that van when it's here once a month or whatever. Well, now there's a dental clinic that's been paid for by some of the dollars that basically, if we don't use it, that resource goes away, so we need to use it. But we're not referring patients because we forget to look in their mouth. We're busy. So we need to start making sure we're asking them, when did you last go to the dentist? And just because, you know, patients with diabetes should get their cleaning twice a year. And just because we haven't had that in the past doesn't mean we shouldn't have it going forward. So let's remember that. And we were going to be able to send patients directly to the dental clinic. They can get their appointments here.
So we're working on like putting a protocol in place. Right now we've asked if there can be a certain number of spots that are, right now community care patients are getting the priority because it's a clinic within community care. We've requested that there'd be a certain number of slots that would be held for external referrals to guarantee that there would be access to the other clinics. Right now it's being reviewed by the management. The held slots would be a temporary thing right now. Starting September 30th, the new Montopolis Southeast Health and Wellness Center is going to open up, and the amount of dental appointments is going to greatly increase. So regardless of whether or not we're able to get something in place right now, the whole landscape of things should change after September 30th, but we'll keep you updated as soon as we can get any information about whether or not those spots can be held. Right now, patients can call and access it, and we'll put together a protocol for that for you guys to have, and then hopefully there'll be a certain number of reserved slots just for people's chronic disease patients.
Right. Can educate.
We're exploring.
Okay, very good.
Yeah.
All right. So once I figure out how long the patients had diabetes and what complications they have, what the setting is, then I ask them about their typical day. And this is really, really powerful because that's when you get a whole lot of information. So I'll tell the patient, tell me about your day. What time do you get up? What time do you eat? What do you eat for breakfast? How do you take your medicine in relation to what you eat? And I never ask them, you know, I ask them to tell me what they're doing, especially around insulin, because what the chart says and what they're actually doing are often very, very different things. And so if I say, are you taking Lantus 30 units at night? They'll go, yes. If I say, how much Lantus are you taking? They'll say, they might say, well, you know, or I might say, what did you take last night? You know, and then or I might look at their book and see if there's see that their blood sugar was 300. What did you do last night? So I'll ask questions like that. And the other thing you get, which is really good, and y'all may already know this, but ask them, you know, what they ate in the last 24 hours. Because you catch them out of surprise, they'll admit to McDonald's and a lot of other things. And if you ask them, what do you eat for dinner? Oh, I have that grilled chicken breast. What did you eat last night? Oh, well, I went to McDonald's and had the double Big Mac. So that sometimes is helpful. But and I always say to them, I don't want to know what your chart, because sometimes they'll be fumbling around looking for their med list when I ask them how much insulin they take. Say, I don't care what your med list says. I want to know what you're doing. Then I give them permission to tell me what they're doing, which is usually very different. So we find out their physical, their typical day. What's your physical activity? Tell me about your job. Are you sitting at your job? Are you up? You know, because I'm not going to push that person to be doing walking 30 minutes a day if they are, you know, they walk all day at their job. Now, on the other hand, if they sit at their job, then I'm going to be pushing them to do that. So I'm kind of listening and self-monitoring. You know, patients usually don't bring their meter because they don't want us to see what they're doing. It's invasive, right? I've actually had patients wear insulin pumps not want me to download their pump because they felt that that was an intrusion in their privacy. But so when they don't show you your meter, there's usually a reason for it. When their books look too nice, so you ask them if they're monitoring, and again, I give them permission to not be monitoring. I say, well, what do you do with that information? Well, if I'm not doing anything with the information, why would you test? But then that opens up the whole thing about we're going to start doing something with information. So now I need you to start testing, and this is how I'm going to use that information to help you get better control. So we talk about what they're doing with a lot of permission to forget. You know, everyone forgets their Lantus. How many days a week do you forget your Lantus? Oh, 4 days a week. Well, maybe we'll just focus on taking it every day instead of increasing it, and then you go too low and play that game. Don't forget contraception for women of childbearing age. You know, this one burns us all the time where patients get pregnant. And we just haven't had that talk. So even on the first visit, I try and talk about it and talk about realistic. Then we're going to do a complete history of physical. Our blood pressure target now is less than 140/90 for patients with diabetes. If they have more than a gram of proteinuria, there's still data that suggests the tighter goal of 125/75, less than, is better. You don't really want the bottom number to go below 60 and the top number to go below 110. So sometimes it's tricky to hit it right in there, but that's the new target for blood pressure. 130/80 is kind of, there's not a lot of data to support that. If you have more than 1 gram, that there is still data to support less than 125/75.
And are you doing that on microalbumin extrapolation, or are you doing 24-hour collections, or what are you doing?
I'm doing, so, and this is my personal opinion, the microalbumin of 30 to 300, that semi-quantitative test, if it's positive, then I like to go ahead and get the actual number. So if it's above, right now I think what your lab currently does is if it's above 300, it reflexes to the quantitative test. My preference is that it would reflex to the quantitative test if it's above 30. Because if you have a patient who has 50 milligrams of protein a day, and then next year it's 250, that means something to me and it means something to them. Because I can say, look at what's happening to your urine protein, we need to do a better job controlling your diabetes. So that's what I do. And then once they're over 300, then I get protein to creatinine ratio. Sometimes I do 24-hour urine collection, but often I'll just use the ratio of total protein to creatinine, which is different. So once they spill into macroalbuminuria, which is more than 300 milligrams per gram creatinine, you need to measure total protein. And more than 1 gram of total protein, not microalbumin, total protein a day is when you would consider a tighter blood glucose control. Okay? All of these patients should be on an ACE or an ARB, and if they can't tolerate that due to hyperkalemia, then they need to be on diltiazem or verapamil for renal protection, and then plus what other drugs you need. Amlodipine by itself is a great add-on, but it's not renal protective.
All of these patients above what cutoff would be on an ACE or an ARB? You said all of these patients, I'm sorry, I didn't catch exactly.
Any patients with diabetes and hypertension should probably be on an ACE or an ARB, but definitely if they have microalbuminuria, if they have more than 30 milligrams per gram protein, they should be on that. It's a little bit, as you know, more controversial if they, whether or not you use it if they are not hypertensive than it used to be. You know, we used to just put everybody on it.
A little bit.
But if they have hypertension, then definitely. Okay. Height and weight, height annually, weight at every visit, dilated fundoscopic exam annually, or as needed. So if they have moderate non-proliferative retinopathy, they're usually bringing them back in 6 months to recheck. So then you would do that. And you have the vouchers. That system's working well. I think you have standing orders, so hopefully nobody's missing that. Your orders are just being included. The oral inspection I'm just highlighting. I listen to their heart and lungs at every visit. I do skin inspection. The thing I wanted to highlight here is insulin injection sites. Patients who are on insulin are taught to rotate their sites. For some reason, what I've noticed is rotating to them means that, or that. That's not rotating, and so what you'll end up seeing is these granulomas under the skin, and they get scar tissue, and then their sites aren't good anymore. So I teach them rotating means this, and that, and that. And if you can feel lumps under your skin, you're not rotating enough. So I can't emphasize that enough, especially teenagers. And then they'll get these little balls of fat right here and here that never go away. We call it lipohypertrophy if they just do that. And so a lot of patients have this because we just don't look for it. So look for that, obviously, if they have acanthosis or other things. And then the foot exam, I think the protocol says inspect the feet at every visit. I don't do it for a young, healthy person with good circulation and a completely normal exam. I do it if they have high-risk feet. So high-risk feet means loss of protective sensation, poor circulation, deformities like callus formation. So I do look at the feet of high-risk, the feet of patients with high-risk feet at every visit. And you only need to do the comprehensive foot exam annually. Okay. Labs, you guys do better than most of the safety net clinics on labs because you've got standing labs. So when you send your letters for your A1C, you're doing great. Every 3 months if they're not at goal, every 6 months is fine if they're at goal. They should have a BUN creatinine and an EGFR annually or every 3 to 6 months if abnormal. They should do that urine microalbumin to creatinine ratio, an initial visit and annually. And again, if they're, if they've got nephrotic range proteinuria, you don't need to keep following microalbumin, just do total protein. If patients have stage 3 CKD or higher, we should be looking at the PTH, parathyroid hormone, and replacing vitamin D as needed. Because that can lead to bone disease if they have secondary hyperparathyroidism. Liver panel, again, we're looking for non-alcoholic steatohepatitis and liver disease related to obesity and diabetes. Lipid profile annually, y'all are great at that. Thyroid stimulating hormone, the protocol says annually or as needed. If they're gaining a lot of weight or losing weight rapidly or a big change in energy, those are the things that I mainly look at for triggers that I need to check TSH more frequently. Okay, so immunizations, we should remember that everyone needs influenza annually, pneumococcus, again, hopefully we can get standing orders for these and they're being done, the Tdap, shingles. Do you all have access to shingles here? Okay. Hepatitis A and B. Hepatitis B is indicated 3 doses for all people with diabetes less than 60 years. If they're 60 to 70, only if you think they're at higher risk. I give my patients, we have twin-rich, y'all don't, you have to give them separately. So if my patients travel to Mexico or out of the country regularly, and I give them Hep A too, but that's optional. Or obviously if they have NASH or liver disease, they should have Hep A vaccine. Okay, education and counseling. This is one where we're going to have a whole other protocol committee meeting to discuss education, what we're doing, what we think, and how to do that. Because we know we're not, right now all the education across the safety net pretty much is being done on one. So these folks are called down and they'll do education on a specific topic. Whether that's a glucagon emergency kit or whether that's monitoring and giving them a glucometer, whether that's medications. Your pharmacist can do medication management and counseling as well about the different medications. Don't forget your clinical pharmacist. They do a lot of diabetes education. I don't believe Maya is a CDE yet, but oh, she is. Okay, Maya got her CDE. So almost all the clinical pharmacists are getting their certified diabetes educator. So we don't use them enough, and they do a great job. Still, we realize that diabetes education doesn't need to just happen one-on-one. It's a very labor-intensive way. So we're looking at classes, videos, other things, and more to come on that as we get it. Medical nutrition therapy. I'll have added another dietitian, Elaine Goodson. And so everyone should have, see the dietitian annually or at an initial visit. Now most of our patients haven't really engaged, haven't gotten comprehensive diabetes education because we're doing it in this one-on-one thing. If you have a lot of money, you should go to a 2-day class. And we haven't done that. So I'm always assuming that patients have not had comprehensive diabetes education, and you can always use a refresher too. So especially if you're doing insulin, mealtime insulin, or I'm sending them to the dietitian. Exercise, preconception counseling, depression screening, y'all do that well. Sexual function, it says in the protocol initial and as needed. I don't always do this at the first visit, it depends on the person, and it's kind of nice to ask nondescript questions routinely, but a lot of times you want to build more rapport, so you can use your discretion there. But erectile dysfunction, bladder emptying, and things of that nature. And then lifestyle, smoking and alcohol reduction. I always talk to teenagers or young 20-somethings about alcohol. They tend to binge alcohol at that age, and that's very, very dangerous for people with diabetes or on insulin because when the liver is detoxifying alcohol, it's not producing glucose for your brain, so you're at risk for hypoglycemia. So my message to them is you can't ever drink without eating. You've got to eat and drink slowly and no shots. And two drinks in a day or less is preferable.
I have a question. So
Yeah.
there would be a risk for hypoglycemia even if they're not taking insulin?
Well,
If
if
they're
they're on
drinking-
sulfonylurea, they might be, right? If they're on insulin, so even people who drink, alcoholics are at risk for hypoglycemia if they're not on, if they don't have diabetes even, because
If they eat nothing.
if they eat nothing
For
and they
12
just
hours.
drink, yeah.
Because their liver.
Yeah, the liver, one of the main reasons that you have a liver is to produce glucose for your brain. At least that's how endocrinologists see it. Other people see it different. But yeah, the liver is a great storage device for glycogen and then glucose. You know, it converts it. So, so yeah. So it depends on what they're drinking. If they're drinking hard liquor, you know, if they're drinking Jack and Diet Coke, that's going to make them have low blood sugar. If they're drinking margaritas or pina coladas, you know, it may go up. It depends on what they're drinking. So I get that, but I think shots are dangerous for anybody, you know, especially young people, and young people with diabetes, it's a big danger. So I talked to him about that at the first visit. Okay, and then more, you know, as needed. All right. So this is just a breaking point because now we're getting away from the this page and going on to the thing. So eat less, exercise more, and alter your genetic code. I wish we could use, but all right. Anybody have any questions on just that quick minimum standards?
Susan, probably another time, but we're struggling so much with the whole NASH thing and what the EGI says and our stuff, and we had that conversation another time.
Okay. About non-alcoholic
Yeah, and
steatohepatitis?
especially in the adolescents, and
Yeah.
it's just,
So
I feel like that's a whole other hour.
it is a whole other hour, but I think we need to be. I have
we're
I have teenagers
screening.
in my practice who have cirrhosis. Yeah. So it's a wow.
Yeah.
And there are some drugs that you're hearing about that might reverse that, and gastric bypass may reverse it as well. I'd much rather do it without gastric bypass if we can, but the GLP-1 agonists, actually there are liver biopsy data showing that reverses it. The TZDs are good for NASH. Metformin not so much, except in that it can help them lower glucose and weight loss, but the drug itself does not reverse it. Okay. So the natural history of type 2 diabetes, as we know, is that by the time you get diagnosed with diabetes, you've had insulin resistance for more than a decade probably, and you're already declining insulin function. So as insulin resistance starts, you start producing, your beta cells increase more insulin, and that can keep the glucose normal. At some point it escapes, your insulin resistance becomes so intense and your beta cell function starts to decline and your sugar starts to go up. So we really need to focus our attention here, because once we're focusing it here, the horse is out of the barn. And Ralph DeFranzo from the Texas Diabetes Institute talks about the ominous octet: decreased insulin secretion, increased liver production of glucose due to increased glucagon, decreased muscle absorption of glucose, increased free fatty acid circulation, and that interferes with insulin secretion, increased alpha cell secretion of glucagon, decreased gut hormones, increased ability of the kidneys to reabsorb glucose, and decreased neurotransmitter function in the brain that affects appetite. So it's all of this stuff. It's not just about insulin. And the further down the road you get, the more things are deranged. Now, at the endocrine meetings in Chicago, one thing that the most exciting thing I heard was we used to think that when insulin secretion went down, it was due to apoptosis, which is beta cell death. And that would be irreversible. The cells are dead. You can't get that back. What we learned is that beta cells are actually being reprogrammed into alpha cells. So you have increased glucagon, which is going to raise sugar, but the lovely thing about that is maybe you can program them back into beta cells. So that'll be the next thing I'll be looking at. But we used to say they were gone, and they're not. So what Dr. DeFranzo strongly believes is that the greatest potential to impact the quality of life of a diabetic is early in their disease process. So what he does is, if he had a new patient with an A1C of 8, he would put them on triple drug therapy from the get-go. They would all get a GLP-1 agonist like Victoza, they would get metformin, and they would get a TZD like Actos, 30 milligrams. Everybody gets triple therapy from the get-go, and the idea is that you shut down their insulin resistance and they will permanently be at that level of control. You get their A1C to goal, and will be there forever. They'll never have to go to sulfonylureas or increase insulin, and it'll be lovely. You know, in a perfect world, if the drugs are perfectly safe, have no side effects, and cost is cheap, that's a great way to go. We're not quite there yet. But we definitely know that metformin is a great drug, and we should use more of it. We should use more of it early, and that we really need to work on patients' exercise and healthy eating early before things get too far gone. The other thing is, it's a great idea to have them work with your diabetes specialty team. They don't necessarily have to see me, but to work with a specialty team, or have one visit with me sometime early in their diagnosis. I don't want to see them 10 years, 15 years from now after their toes cut off, or when they're on dialysis. You know, I want to see them now, or at least the team members. I'm just going to take 2 seconds to talk about the diabetes prevention program. This was a big multi-center trial in the United States, a little over 1,000 patients in each arm. They were randomized to either intensive lifestyle, and I'll tell you what that means in a minute, metformin, or placebo, which is what we call the usual care. The lifestyle intervention was intensive program. They were told to lose 7% of their body weight. Their dietary fat goal was 25% or less of calories from fat. Calorie intake 12 to 1,800 and 150 minutes per week of physical activity. But it wasn't just telling them this, we tell them that all the time. It was a 16-section core curriculum over 24 weeks. After the first 4 months, so they went every week for 4 months, and then they had a long-term maintenance where they went once a month. They had a case manager who was calling them. They had a lifestyle support staff. They had a dietitian, a behavioral health counselor, and an exercise specialist. So all those people were watching them. And this is the Kaplan-Meier plots looking at incidence of diabetes over years, okay? So at 1 year, you know, that's the incidence of diabetes. This is the placebo, the usual care. This is the metformin group, and this is the intensive lifestyle. So at the end of 3 years, if you got the placebo, 30% of the patients had diabetes. If you had metformin, 20%, which was a 31% reduction because you went from 30 to 20, okay? And then with the lifestyle intervention, a 58% reduction. So the lifestyle choices were twice as powerful as the metformin, but this is the intensive program. It's not exercise 30 minutes a day and one visit with the registered dietitian, which is usual care.
Well, it's less than 30 minutes a day of exercise. It's ridiculously low exercise.
It's ridiculously low, but the lifestyle people, even with the ridiculously low goal, with the intensive approach of lots of support people, and they reduced their risk, okay? And so the good news is that in Austin, we have the diabetes prevention program at the YMCA. So you can actually send people for that 1 year intensive course. The cost of it is on a sliding scale. I think they can get it for as little as $130 for the whole year. And they can divide it up in payments. So if the full price of it, I think, is about $260, but they give a sliding scale payment. They can pay it out in payments, and they get that. They get 3 months of during the intensive part of a free YMCA membership. So I just want you to know about that because it works. And I think that you can buy a lot of gym membership for the money we're spending on drugs, and especially at the YMCA, and we ought to be doing more of it. So what I like to do is, because I send patients, I've sent a lot of patients to the DPP program at the YMCA, but I also do metformin because I realize that if they don't go to that what we're telling them was the placebo arm. And I don't want to randomize my patients to the no treatment arm.
And how?
So, yes.
But for the metformin, like, is there like a hemoglobin A1C that you would start, and how young of an age would you start? Because obviously we're seeing diabetics.
Yeah.
Do you start at 5.8 and they're 15?
I start with I start with any abnormal. So if I had, and I'm more likely to use metformin if they're obese and have acanthosis and, you know, the right ethnic group where they have, you know, if they were skinny and Caucasian with an A1C of 5.7, I probably wouldn't. If they were obese and African American and acanthosis and both parents have diabetes, I probably would. You know, so I take a little bit of context, but if they have prediabetes based on an A1C of 5.7 or above, I'm probably offering metformin. Yeah. Now I have some. So here's a case that sort of fits this. So this was a 28-year-old woman who was sent to me by the registered dietitian. And she'd been working with the registered dietitian in our system for a long time. And she hadn't, it's interesting, somehow she hadn't been seeing a primary care provider really. She'd just been going to the dietitian. She was trying to limit her calories to 1,200 a day. She tried the Atkins and didn't lose weight. Her BMI is 50, so that's really not enough calories for somebody with a BMI of 50, so I have some questions there. But she had a documented weight gain. All she did all day was read. And she had ulcerative colitis, and what she said is that when she was diagnosed with ulcerative colitis, she had to take prednisone several times a year. The GI doctor, her liver doctor, told her that exercise was stressful to her and she shouldn't do it. And I don't really think he told her that. That's what she heard. And so she thought, I'm just supposed to rest. And so she would read all day long. And she had irregular menses. Her family history is positive for diabetes. She did have a goiter, interestingly. And she had elevated total cholesterol, a pretty lowish HDL for a 28-year-old at 47, a high LDL, A1C of 5.7. A random morning cortisol was 19, which is in the high normal, and normal thyroid function tests. So, what should we do next? Do we want to talk to her about her options? Do we want to recommend metformin? Do we want to ask her to attend the pre-diabetes class at the YMCA? What do y'all want to do?
She needs a dog and walk her twice a day.
Find a dog!
And start metformin.
So, let's just see what happens if we, I don't know if this is going to work or not. I have this interactive thing here. All right, so let's say that we offer her metformin. Well, the problem with metformin in this young lady is that I use the dose for prediabetes for me for metformin is usually 2,000 to 1,500. And metformin reduced the risk of progression of prediabetes to diabetes by 30%. So we could tell her that. I'm going to tell you she didn't want to do drugs, and with her ulcerative colitis, metformin and diarrhea makes that a little dicey. So actually what I did for her was I referred her to the DPP is what I ended up doing. Well, let's see if that works. Okay. So I ended up doing that with her. But she was very adamant she didn't want to take medications. But I think we should do something. And if she, you know, if I see her back, and I also ruled out Cushing's. I did an overnight dexamethasone suppression test that was normal. But, you know, I think that with her, I just really tried to say, because metformin and your ulcerative colitis. Oh, the other thing I told her is to stand while you're reading. If you like to read, commit to standing and walking an hour a day instead of sitting. Why not? Yeah, at least you're moving. Okay. So that sort of is the pre-diabetes piece. Now we're going to move on to the diabetes piece. So what is our A1C goal? Because what we're going to be doing now is going to the medicine algorithm. You all have it in your packet. And why don't you turn to page, no, well, we're going to use that too, but it's page 7, I think. Yeah. This is I hope this page 7 of the thing, I hope this page is going to be your new big friend. It's the oral treatment algorithm. So when you have somebody on treatment, the first thing you're going to do is think, what goal am I trying to get to? Am I trying to get to less than 7 or less than 8? Okay? And then once I know what goal, then I can look at the algorithm and see where I'm entering and decide what medicines to choose. So we say that if someone is on a medicine that does not cause hypoglycemia, then their goal is as normal as you can get it with, you know, on that drug regimen. So if you're on metformin only, and I've got a patient, let's say they start with an A1C of 6.5, so they really have diabetes. I put them on metformin and I get their A1C to 5.5. Am I happy? Oh yeah. Am I taking away their metformin? Probably not, at least not right away. I want them to get some, I'm telling them it's not about glucose, it's about insulin resistance. And so if your A1C was 6.5 and we looked at that slide that said that their disease process was going on for more than 10 years, just because I got your A1C to 5.6 in 6 months with metformin and lifestyle doesn't mean your insulin resistance is gone. So let's keep the drug for a little while. Now sometimes if they've lost a considerable amount of weight, maybe after a couple of years they've lost weight, they're exercising, maybe I'll withdraw metformin then, but I don't do it just because their A1C initially lowered, okay? So I want their A1C normal as long as it can be, because again, if I can do that with a single drug and I don't have to go to sulfonylureas or drugs that raise insulin levels down the road, I'm very happy. So your A1C, if you're on a single drug therapy of metformin, it's as low as you can get it without causing them to be sick with side effects or, they usually won't get hypoglycemia on metformin alone, but they might if they went all day without eating, because remember that it affects the hepatic production of glucose. So for pre-diabetic, that's why you don't go above 1,500 milligrams, because you really can't make them hypoglycemic. But if they have diabetes and they're on 2 grams a day, I want their A1C as close to normal as I can get it. Now, if I'm having to add multiple drugs, I'll be happy with less than 7. Okay? But what patients do we let them be higher? We let them be higher if they have evidence of advanced or poorly controlled cardiovascular and microvascular complications, hypoglycemia unawareness, so it's not safe to get them lower, or if they're vulnerable. One of the things that it says in the protocol, if they have a life expectancy less than 5 years, you don't need to get their A1C to 6.9. If they've had diabetes for 20 years, the VA diabetes trial showed us that you actually increase their mortality if you get them below 7. So, my cutoff for pushing people below 7 is whether or not if they're on insulin or sulfonylureas and they've had diabetes for more than about 15 years, you might do harm, and so let them be 7.3, 7.5, that's fine. Okay. There's lots of data to support that. But if they're just on Janumet, you can get them lower. Anybody have any questions about how low you're going to go or what your target's going to be? Okay. Okay, so let's, in the slides, there's some slides that tell you about the specific studies that support what I just said, so you can look at those later. So this is sort of the protocol then. If you have a patient who's new to you, and they don't have to be new to diabetes, but who you're seeing, and their A1C is between 8 and 9, for example, they're probably going to need 2 drugs to get to goal. So you're not going to start them on 500 milligrams of metformin and see them back in 3 months. Okay, that would take too long. You'd take forever to get to your goal. Now, if they have 7 to 7.9, then you can start them on metformin by itself. You check them in 3 months. If they're still above 7, and you're going to titrate up the metformin pretty rapidly. So again, it depends on the patient. If you have a patient that is young, healthy, not afraid of medications, doesn't have irritable bowel syndrome, or some reason, you might say, start with 500 of metformin and after a week go to 1,000, after another week go to 1,500, after another week go to 2,000. And sometimes we do it over a month. But if you've got, your patients, if you've got somebody who is, has chronic diarrhea or irritable bowel syndrome or pain or is very scared of meds, you might start them on 500 and then have them follow up with Liz in a week and see how they're doing, and she can go up. And we're talking about getting protocols where the nurses can increase them for you. But the bottom line is you don't want to start 500, wait 6 months to do something. You want to increase it, and if in 3 months they're not at goal, you're intensifying therapy, yes.
What about continuing metformin as creatinines creep higher? It's a harder question than starting it fresh.
Yeah. Everyone should be on metformin if their creatinine clearance is, if there's no contraindications. For me, the cutoff is 60, but it's more than one value below 60. So if I have a patient that's dipping around, and that their EGFR, let's say, is 80, and then one time I get a 55 when they were dehydrated, I'm not going to start metformin for that. I'm going to follow them, and if it comes back again at 55, then I'm going to stop it. But if it reverses or pops back up to 61 or something, I'll continue it. There's pretty good data that metformin in a 50 to 60 range probably isn't a problem. It's when it can dip down, you know. And so for those patients who are on the border, I'll watch them a little bit before I decide to stop it. Now, if they have had a rip-roaring ketoacidosis, and some of our type 2 patients can get ketoacidosis, I might be a little bit more, or if it's a type 1, we're not talking about type 1, but some of our type 1s have type 1 too, right? They have insulin resistance and type 1, and they have frequent DKA. I don't want to use metformin because lactic acidosis can compound. But if they don't ever have DKA, I'll use metformin even in a type 1 who is also insulin resistant. Other contraindications to metformin might be severe liver disease. Rich and I had one of those where the guy had cirrhosis more than I realized. I started metformin and I think he bumped his bilirubin and his LFT. So be careful at a patient with cirrhosis, because remember at cirrhosis, sometimes their baseline liver functions look normal, but I just didn't realize how bad his liver disease was. So anyway, or somebody who's hypoxemic, if they have like very untreated, you know, sleep apnea, I might not want to use metformin in that patient if they're, you know, but otherwise you can use metformin. But let's say they come,
I'm just going to interject here. For people that aren't as familiar with some of these terms, there is a glossary at the end, like what does DPP4 mean for some of the folks that are less familiar. And one of the good things that the CCC has been doing is they've been trying to come up, there's a med list. They're trying to work through the protocol for what's going to be available at what cost, who's going to be able to get what where. And they've actually done quite a bit of work on that. So as you think about this as an ideal protocol, there's a lot that's been going on to make it potentially realistic. And so you might need to do some cross-referencing with the glossary, and I've got some information on the medications. I don't think that's in this.
I didn't do that.
I brought it
Rich.
with me, and we could make copies of that.
Yeah, we'll
But
make
it
sure.
actually discusses what are those drugs,
Yeah.
the DPP4s, what are the GLP-1s, and I think many of us need that information.
And I'm going to talk to you
That's
about
right.
it too, a
Yeah.
little bit more. And this one will go to, so yeah, so,
Can I just say that
yeah.
Elizabeth and probably, Maya just got a second, but probably pretty soon, I will know really well, like, what are the cheapest ones to get where, if, you know, figure it out. So if you have questions about it, you know, what is a good option, if we have time goals, and are they gonna be able to get P-copies, and, you know, what is going to be the social security number,
So that, yeah, that's where your team can help you as we figure it out. And then once you've done this a few times, you'll get it. For example, but if the patients have a higher A1C, then you're going to want to do dual therapy. Now again, this is what we suggest, but we understand every patient's different. If you've got a patient who thinks that every medicine's going to kill them, you might not want to start 2 drugs at once. But then, you might want to bring them back in a week or 2 to start the second drug. You're not going to wait a whole 3 months if their A1C is 8.9. You're going to do, and that's when again you'll call your nurse and say, okay, I'm going to do this. You check on them in 2 weeks, and you know if the sugar's still high, we're going to do something else. So most patients with an A1C, most single drugs lower your hemoglobin A1C by 1 percentage point. So if your goal is less than 7 and you're starting at almost 9, you're not going to get there with metformin unless you do other things. And again, this entry point makes a difference if you're a brand new diabetic versus a long-term diabetic. If you have somebody who's lived with an A1C of 8 to 8.9 for 3 years, and you're adding another drug, you're not going to expect to get more than about a percentage point improvement. However, if they're brand new diabetic and they're getting education and they're all excited about lifestyle and they're exercising and changing their diet all at once, you may well get 2 or 3 percentage points with one drug, right? Because they're in transition. So be aware of that. Is this a new condition, or is there some glucose toxicity involved, steroids or something, or is this a chronic patient who's just been getting a little bit worse over time? But most patients with a hemoglobin A1C between 8 and 8.9 will need dual therapy, metformin, and we recommend if their body mass index, and that's what this page tells you, if their body mass index is above 30, so if they're in the obese category, your second drug should either be a DPP-4 inhibitor or a GLP-1 agonist. So, what are DPP-4 inhibitors? They are the drugs that block the metabolism of glucagon-like peptide 1 and gastrointestinal peptide, GIP and GLP-1. So they're oral agents like Januvia, Tradjenta, Onglyza, and a lot of them come is combos with metformin, so you could get them through the prescription assistance program, and we use those a lot. The GLP-1 analogs are the injectable ones. They're the agonist of that receptor. Typically with the DPP-4, they're not as powerful. You get about 0.5% or 0.6 lowering of the A1C. GLP-1s usually get you closer to 1% or even more if you're losing weight. Okay, so GLP-1s are like your Byetta Victoza. Byetta is no longer available through prescription assistance. So for you, practically speaking, unless we can get that 340B pricing, you're going to be using Victoza through prescription assistance, and you do need a social for that. Again, the CCC is looking at whether or not we're going to be able to get special, deals. I know at community care, Byetta is going to be available through the central pharmacy. So through the CCC, we might be able to extend that to your patients too. We just don't know. We'll be figuring that out.
We're
But
trying to figure that out for Januvia too, right?
Yeah.
There's some special pricing that we're trying to see if we can get.
Yes, I've talked to Dr. Hernandez at the CCC, and he's willing to look at it with us, and he's also going to help us get in touch with the right folks at community care to see what the mechanism they have for getting some of these medications at a lower price.
so what about Januvia and Victoza and Tradjenta? As you may have known, a couple of years ago, year and a half ago, a lot of people were talking about pancreatic cancer with these drugs. These are called incretin-based therapies. I worried about it because what they do is they stimulate pluripotent pancreatic cells. And so if those cells can differentiate into ductal cells and cause ductal hyperplasia, and that was one of the mechanisms that was predisposed to how they cause pancreatitis, and the risk of pancreatitis is low, but it's probably real. So there's a mechanism by which maybe they could cause pancreatic cancer. So I worried about it and didn't prescribe them for a while. And my patients watched late night TV and said, Dr. D, these will kill me, I'll get cancer. So that's why I copied this article for you. After thinking, so what happened is, when that data came out, there were two doctors who were talking about this, one at Johns Hopkins and one in San Diego, and people were worried about it. The Food and Drug Administration and the European Medicine Agency independently looked at all of the data that was available. They ran new animal studies, and they looked at all the human data. And both agencies came out in the New England Journal this year saying, we don't think there's a real risk with this. And again, if we're talking about pancreatic cancer risk, we're talking about, if the baseline risk is on the order of, I think, 6 cases per 10,000 patient years, it might be going from 6 to 8 or 9 cases. So it's not a huge risk. There's a risk of cancer just with obesity and insulin resistance. So after getting this, I felt more comfortable, but sometimes you have to have this discussion with your patients, because if you don't, and they watch late night TV, they'll say, I'm not going to take that drug, it gives me cancer. Yes?
How much have you seen pancreatic cancer be a cause of a presentation of new onset diabetes? I believe I've seen that twice.
Oh,
That someone I was treating for diabetes, type 2 diabetes, and by golly, 6 months later it became clear it was pancreatic cancer.
I think I've probably seen that maybe once.
Okay, so it's not in the stats. It's not enough to be in the
I don't think it's a huge
stats.
thing, but any pancreatic destruction, and certainly, diabetes is so common now, so I think that it's an interesting thought, but.
Just wondering.
So I have thought about this and worried about the people, endocrinologists and at the endocrine meetings, this is what people are saying, these drugs, the GLP-1 analogs like Victoza and Byetta do seem to reverse NASH. And that is a risk for hepatocellular carcinoma. So you start looking at all this stuff. I think the risk-benefit ratio, if we discuss it with our patients, I always talk to them about pancreatitis. If you get abdominal pain and vomiting, stop the drug. If, you know, if you have to, you know, if it's on the weekend or something, go to the emergency department.
Just
or
as
call
another
me.
little aside, there's a whole form here on some of the risks, benefits, advantages, disadvantages of the various agents, and that's useful to use for
We
patients
gave it to you in color.
too. Yeah.
Are there age cutoffs? Like how young would you use?
I don't know the age. So for me, I see down to 16 years old, but you're right, and your 13 and 14s, I don't know. I just don't know, I'm sorry. You're gonna have to ask. And I think they're not recommended at this time based on my reading, but they might be if there are more studies. There's not a lot of studies in adolescents.
But 16 and up?
I think so. Again, I'm not sure if it's FDA approved for 16, but if you had somebody with, I think you could make a case for it, yeah. Okay, so we have a lot of different options for what that, so the protocol says at this point you would use dual therapy and you'd recheck at 3 months. If they're still above 7, you'd go to triple therapy, okay? Now you might say, well, gee, what mismatch of this, you know, we've got all these choices. Which ones am I gonna choose? Well, so this, it's something that you're gonna have to get comfortable with over time, but this sort of tells you, you know, the more powerful ones are metformin, GLP-1s, TZDs. The problem with Actos, which is our prototype thiazolidine is that you get weight gain with it, you can get bone loss. So if you give it to somebody lifelong, are they going to get osteoporotic fractures as they get older? Will they get, you should never give pioglitazone to somebody on insulin. It's too high a risk of congestive heart failure. They get lower extremity edema. I think I only have one patient left on pioglitazone. He's done well for a really long time, and we're just leaving it alone because I'm afraid if I withdraw it, he'll need insulin. Dr. DeFranzo has almost all of his patients on pioglitazone, and Avandia is coming back, by the way. The FDA relieved some of its concerns about coronary artery disease and increase in MLIs with that. So the TZDs aren't going away, but they're not my preferred third drug, okay? There's no data to suggest giving a DPP-4 and a GLP-1 together is a good idea. It's a very expensive regimen, and the preferred one is a GLP-1 because it's more potent at lowering glucose and at weight loss. But if they want an oral agent, you've got your DPP-4. But if they're on Janumet and I'm deciding to go to Victoza, I take away the Januvia, okay, just so you know that. So I wouldn't use those two together. Okay, what are other ones? We use sulfonylureas a lot. Sulfonylureas, I think, got a bad rap. Sulfonylureas have less severe hypoglycemia than insulin-based regimens. As long as I don't like to use glyburide very often, and I certainly don't use it in elderly or people with renal insufficiency or congestive heart failure, because I've seen severe hypoglycemia last 4 or 5 days in patients on glyburide. So I don't like that one. But other than that, glimepiride, glipizide, they're fine agents to use. And they're great agents to use for a new diabetic with glucose toxicity. Maybe they come in with an A1C of 9.5. You start them on the sulfonylurea and the metformin together. As you titrate up the metformin, you can titrate back the sulfonylurea. And then if they lose weight and things, you might add a DPP-4 and get them off the sulfonylurea. But a lot of times when you have a new patient with a very high sugar, you need to get your insulin levels up. And whether you do that with injectable insulin or sulfonylureas, it doesn't much matter. With sulfonylureas like glimepiride, you can give a 4 milligram tablet once a day. They can break it in half and get 2. They can take 2 and get 8. So you can titrate. You can do the same thing with the 5 milligram tablet. Break it in half, 2.5 twice a day, 5 twice a day, 2 twice a day, which is 10 twice a day. So you can use those drugs and titrate the sulfonylurea up and down. And then I tell them keep your metformin the same. You know, your drugs that don't cause weight gain, you can do together. So a nice triple regimen is a DPP-4, metformin, and a sulfonylurea. Okay? All right. And then if the A1C is very high, if it's over 10, we're talking about insulin. But let's look at this case. 23-year-old Asian man I saw here, severe cognitive impairment. So this young man had cerebral palsy and was not able to tell us What?
So that's my question.
I am
He was on metformin, 1,000 milligrams twice a day. He's not overweight. He's got a little tummy, but he's not overweight. So what do we want to choose for that guy? We have a lot of choices. So what would you add next? Well, we could do all these things. Which one do we want? We could do a DPP4 inhibitor. We could do sulfonylurea. Why might we not want to do sulfonylurea? Because it can cause blood sugar. P-glitazone might be a nice choice for him. He tried it in the past, and his mother felt strongly that it made his behavior bad and did not ever want to go there again, but that would have been a choice. GLP-1 agonist is injectable. Mom didn't want to do anything injectable. Alpha glycosidase inhibitors. Let's look at that. Okay. So those inhibit enzymes that break down carbohydrates. So alpha amylase, maltase, isomaltase, and glucoamylase and sucrase. So it breaks down sugar digestion. So the side effect would be diarrhea or loose bowels. You can get about a 0.5 percentage point lowering with these, so they're not particularly powerful. What about Welchol? That's on our list. It is Colicibellum, I can't say it right. It's a lipid-lowering agent, approved for diabetes use in 2008. Again, it's one of those weaker ones. You only get about 0.5 percentage point. Mechanism for glucose lowering is unknown. Lowers LDL a little bit, so that's nice, but it has the potential to increase triglycerides, so you wouldn't use it in somebody with triglycerides over, 300 or 400. Main side effects of this one are also GI and also drug-drug interactions. Remember that this one binds bile salts. It actually raises metformin levels and it lowers sulfonylurea levels when taken together. And so they have to take this drug either 1 hour before or 4 hours after other medications. It's kind of hard. So it's, it's expensive. So it's not a great one. I just wanted you to know about it because sometimes these are little niche drugs and adjunct. Cyclocet. This one is not available on PAP. I had one patient I really wanted to use it on. She did not want to do sulfonylurea. This one was approved in 2009 as a monotherapy or adjunct for type 2 diabetes. It comes in 0.8 milligram tablets. It's bromocriptine, but it's given in this quick release way that you take within 2 hours of getting up. So it's not the bromocriptine we use for galactorrhea or prolactinomas. That's a different drug. This is a quick release. You take it in the morning. You start with 0.8 milligrams and you add a tablet every week. The therapeutic range is somewhere between 2 and 6 tablets a day within 2 hours of waking. Potential side effects: nausea, constipation and diarrhea, orthostatic hypotension. I love it, hallucinations or psychosis. That's just what we need in clinic. But you can't, it's not a palpable one. If you have some patients maybe with medication or something, you can get it. And then we have these new ones, Indocana, and these are the new SGL2, which is the sodium glucose cotransporter 2 inhibitors. So basically what happens is, in the proximal tubule, all of the sugar is reabsorbed back into the bloodstream. But these block that, so it causes you to excrete more glucose in the urine, which theoretically is nice. Get rid of. So remember that some patients with diabetes use hyperglycemia to lose weight on purpose, right? They drive their sugar up so they can get rid of calories in the urine. Well, what if you could do that without driving your sugar up? That's basically what these drugs do. They do induce glycosuria, improved glycemia. They can reduce A1C, again, up to 1%. Low risk for hypoglycemia, that's nice. And modestly reduce weight and blood pressure. However, you can get vaginal yeast infections, polyuria, and then may increase the risk of ischemic stroke. Didn't like that one. Especially early in treatment, probably through volume contraction. Could increase, the other thing is it definitely increases glucagon levels by about 30%. So, and that's an early on, and that's what, again, so they may get hyperglycemic volume depleted due to elevated glucagon early on, and then that escapes later, so that risk kind of goes away, but in the early times. So honestly, I don't have anybody on these drugs yet. I'm the conservative person, wait a year and see what happens, and then maybe we'll use them. But these might be coming down the pike. A lot of people are real excited about these. And you can potentially be looking at using them with insulin as well. So that's so what we did with our kid though was we put him on Tragenta. It worked like a charm. And his mom was thrilled. His A1C went from 8.3 to 6.5. He lost a little bit of weight, but not a lot. He still looks healthy. So yay.
Is he someone who you checked like C-peptide or insulin level on at some point in time, being so, kind of mysterious?
Yeah, I think we've done a
His
C-peptide.
dad, they're Korean, and
Yeah.
the dad has diabetes, and I think it's just purely genetic.
Yeah.
mean,
Oh, I
he's
would
not
still always
overweight,
check on
but
someone like
his dad's diabetic, yeah. No, it's definitely.
And we do, and so one of your decision points is the patient really got type 1 diabetes of the latent autoimmune onset? So that's the LADAs, latent autoimmune diabetes of adults. So they present very slowly over a decade or so with type 1 diabetes. And so the way that you can figure that out is by checking C-peptides and by checking antibodies sometimes too. The antibodies I check are the GAD65 antibodies or the IA2A islet cell antibodies. And if those are positive, the question is, do you put them on insulin right away or do you wait until they need it? If I've got an intelligent person that is going to check their sugar and let me know when they're, and I would always have that person doing postprandials because they might not pick it up on fasting. If I have an intelligent person that can let me know, I'll keep them on oral agents as long as they can. But then when they escape, they have to go on insulin. If I have somebody I'm worried about, I might just put them on insulin from the get-go. But yeah, he did really well in that therapy. And we really don't want to inject this kid if we don't have to. Okay, so let's do another one. 38-year-old Latino man, type 2 diabetes since 2004, so 10 years into diabetes. He has non-proliferative diabetic retinopathy as a complication. In February, his A1C was 11.3, and he was added to triple therapy. Januvia was added to metformin and glipizide. Would we expect him to get to goal with that? No. So if we'd have done our protocol, we would have done insulin back here. But the patient was kind of reluctant. Okay, I'm seeing him 2 months later, and this sort of basically what the provider told him is, I'm going to do this now, but if you don't get under control, we're going to do insulin next time. And that really scared him. And so with remember we'd expect Januvia to get us a half a point down, but look at his readings. They went all the way down. He still had a pretty high fasting, 208 to 218, but he came down during the days. He was more physically active, and by supper he was in the 138 to 180 range. So this is an example of, Januvia didn't do that, but he got scared and did lifestyle. And so when I'm seeing him, now I don't think he has an A1C of 11.3 anymore. I think he has an A1C probably more like 8 or 9. So what would you do now?
Scare him some more.
I would give him a high five. I would give him a high five and a pat on the back and say, keep up that good work. Let's talk about what you're doing.
So we did give him a high five, but we also started basal insulin because he still had a high fasting sugar, okay? So my question is, did you want to do just the basal or the basal bolus? So the algorithm says if you have a patient that you're starting insulin on and their A1C is above 10, then you need to do meal insulin too, okay? But in this particular guy, because he came down so nicely during the day, we just did basal insulin. So how do you do basal insulin on somebody? This is straight from the algorithm, folks. So the algorithm now, we're on page 9, basal insulin algorithm. So we use it in patients who have an A1C less than 10. If it's more than 10, you need to do mealtime insulin too. But in this guy, we think his A1C is less than 10 based on his reading. So we're going to calculate his starting dose as 0.2 units per kilogram body weight, or start with 10 units. So you give the Lantus about the same time every day. In In the evening, if the fasting glucoses are the highest, like our patient, so he was 259 pounds, 117 kilos, that's 23 units. Now, he was already going down into 140, so I was kind of thought, 23 sounds like too much. Let's just give him 10, okay? And then you can go up by 2 units every 3 days until you get the fasting. Or if the patient's not able to titrate, you can say, Liz will call you next week and she'll tell you over the phone what to do. And then she would titrate by 2 units every 3 days. So you get the fasting to range without hypoglycemia in the daytime. So since his lowest sugars are in the daytime when he's moving around, basically I stop when they get to the point where they're feeling like they have to eat to keep their sugar up, eat more than they normally would. Unless, of course, they're going all day without eating, and then I'll add snacks. But pretty simple. Okay, now here's a different one. This is a 58-year-old woman. She's had type 2 diabetes since 2007. She left the clinic in 2011 when her hemoglobin A1C was 12 because she was healed. However, she came back
Relapse.
with severe fatigue, a 22-pound weight loss, polyuria, polydipsia, and a glucose of 504. She had nausea, no appetite. Her ketones were negative. She eats only 1 or 2 meals a day is what she told me. But she wanted to feel better. So the first thing we have to do is think about, well, her glucose is 504. Is this a patient I need to send to the hospital, or can I deal with her in my clinic? So, page 24, the emergency department referral when the patient is physically present in the clinic. We would refer to that. We'd say, well, is she symptomatic? And I mean, she was symptomatic in that she had polys, but she wasn't vomiting. She didn't have a severe headache. She felt generally weak and not great. But her ketones were negative. If her ketones were high, I would have sent her to the hospital and had her get admitted. She wasn't tachycardic. She didn't have new onset glucose greater than 500. She'd been living there for a really long time. She wasn't pregnant. And she didn't have any of these alarm signs and symptoms. She had no altered mental status, no chest pain, no shortness of breath. She was not vomiting. So if she had any of these things, I would have sent her to the hospital. But she, other than being weak and generally feeling crappy because she'd had a sugar of 500 forever, she was okay. So we ended up just starting insulin. So how do you start insulin when the A1C is greater than 10? Well, now you have a choice. You're going to do basal bolus or you're going to do fixed mixed. And what I usually do is I offer the patient both choices and let them choose if it's available to them. If they don't have a social, maybe they can't get Lantus or Levemir, maybe then I'm just doing this. But if they have a choice, I'm going to say, you can do this regimen, you get more flexibility, you don't have to eat on time, you can adjust your insulin based on what you're eating, or you can do this, you have to be consistent about your eating times, you have to eat 3 meals a day, you have to eat about the same amount of carbs, so then I let them choose. But I always say, guess what, if you decide to make a different decision next week, that's okay. You don't have to stick with what, I give them the freedom to, let's try this, and if we don't like it, we can do the other one. And that way, they just get a little bit more courageous about it. Okay, so if we're going to do the basal bolus, you have to calculate the total daily insulin dose based on the body weight, actual body weight. So 0.5 units per kilo. She's 242 pounds. So 110 kilos, that's 55 units. You give half this basal and half this bolus divided by their meals. So 55 divided by 2 is 28 of Lantus. Or if you're giving Levemir, you're going to split it twice a day. Because Levemir at doses of less than 0.4 units per kilo doesn't last 24 hours. So if you give Levemir at a dose of 0.2 units per kilo, it's only going to last 10 or 12 hours. So if you give it at bedtime, they're going to be uncovered during the day with basal. So I just would either do 28 of Lantus or 14 of Levemir twice a day. I gave her 25 of Lantus to make it easy. So I'll usually do the calculation and give a little bit less. And then 28 units, so we take the other half, divide by meals, that's 9 units pre-meal, but she only ate 1 to 2 meals a day. I just said take 8 units before you eat meals with carbs. And if you just eat salad and chicken, you don't take that other insulin. So that's kind of how we did that. She did really well. If you had to do fixed mixed, you do it the same way, 55 units. And the traditional way was to, well, you give 2/3 is NPH and 1/3 is rapid. But remember that 70-30 mixed insulin already comes that way. And then you can give 2/3 in the morning and 1/3 in the PM, or half in the morning and half in the PM. So I do a meal history. If their largest meal is breakfast and lunch and they eat a small supper, then I do 2/3 of this dose in the morning and 1/3 in the evening. If they don't eat much during the day, they're physically active during the day, they don't eat much, they eat a big meal at night, then I give half and half. Does that make sense? So this would be 26 units twice a day of a 70-30 mix. Okay, and then you just bring them back and tweak it. So it really works. So I'll always do the calculations, and then I'll ask them if they're comfortable, if it sounds okay, and I always give them a phone number of somebody they can call in case they're having trouble or forgot. So that would be your wonderful nurses who could field those calls if they were having any issues. So we'll stop there for a second. Are there any questions on starting insulin? We did the protocol. Yeah.
So there's been some discussion about, I guess, when they look at research on how often should type 2s really be checking their blood sugars. Like in the family practice literature, because they look at everything based on Cochrane's, and they're like, well, it doesn't look like it's.
Well, it depends on what you're doing with the data and
Right.
who's doing the research, right? So in my population, there are some people who check their sugars and don't get a whole lot out of it. There's some people who check their sugars 10 times a day and get a whole lot out of it. So it depends on, are they, and there are some people who check their sugars 10 times a day who are obsessive compulsive, and I want them to decrease the amount they're checking because they actually make themselves sick by checking it so much. So it's patient dependent, but if you have a patient who's only on metformin,
Yeah.
I have them check once a day or sometimes twice a week, it depends. And I have them check and alternate, sometimes fasting, sometimes 2 hours after a meal. Sometimes they get a lot of good information that helps them make better food choices, but not everybody has to check. If you have a patient on sulfonylurea, they should all have the capacity to check because they can get hypoglycemic. And you don't want them to be stuck. And so if I'm titrating a sulfonylurea, and I might have them check twice a day, even though Medicare only pays for once a day if you're on oral agents. But if I'm titrating your sulfonylurea, how are you going to know? So I usually have to get special permission, say that I'm titrating a sulfonylurea. If they're on insulin, they can check up to 3 times a day. I have patients who are on insulin pumps who don't even check 3 times a day. That's not ideal, but some of them just won't do it. I had a patient the other day who has been here yesterday, who is lovely, and he just doesn't like to buy strips, and he has maintained his A1Cs on 4 shots a day in about the 8 to 8.5 range, and he never checks. And I'm always shocked that he can be that good without ever checking on multiple injections. But the reason is he's not obese, and he eats consistently, and he does everything about the same, so it works out. So again, if you have that person who's changing what they're eating all the time and doing crazy stuff or overeating, then checking more might help them. And I usually, if patients are on sliding scale, so then I have them check before meals. If patients are on oral agents and you want to see the worst, I have them check 2 hours postprandially. So it just depends. Yeah.
What do you expect it to be 2 hours postprandial?
Again, it depends on what they're doing. So less than 180 is okay, but I might have some patients who I'd like them to be less than 140. I mean, if you're pregnant, you need to be less than 120 2 hours after. But usually somewhere between 160 and 180 is what I tell them we're looking for 2 hours after a meal. If you're frail, 80-something, might be happy with less than 200. But it depends. But around 160, 180. And again, how low can you get without causing hypoglycemia? If you feel hypoglycemic and you start eating everything, when your blood sugar hits 100, that's not good. So then I'll back off a little bit, or I'll make a deal with them. How low do you think we can get your sugar? We're not going to go from an A1C of 13 to 7 overnight, so I'll be okay with giving a fasting under 200 for a little while. you know, and then we'll get to 150, and then we'll get to 120. So that's a little bit of a negotiation when I'm doing it. What are they comfortable with? Always wanting you to know this is the goal and why, but we can get there on your time scale.
What if you have like a brand new young patient that's say 28, 29, they come in and they've never been told they had diabetes and they're like 11, their hemoglobin A1C, and they just don't want to start insulin, you know, they're shocked to know they have diabetes, and you start them on metformin and they really, and you tell them all these good things about changing lifestyle and they actually improve. That's okay. I mean, do you have to do the insulin right away?
Again, I mean, there's, you know, you just, all you can do is the best you can do. I would recommend it to the person, and if they absolutely say no, say okay. And then, but that's a person with that, I'll put them on a sulfonylurea, one of the drugs has to be a sulfonylurea if their A1C is that high. And then I'll say, we're gonna check you back in a couple weeks, and sometimes they will do it, and they'll be in the ballpark, I call it. You know, if they have numbers, say after 2 weeks, they have some numbers in the lower hundreds, or even an 80 or 90, and some of them are still high, I consider that good, they're in the ballpark. But if all their numbers are still 200 and 300, then I'll say, yeah, that didn't work, and now we've got to do insulin. So, yeah, I mean, you can't make anybody do anything they don't want to do. What I'll talk to them about is glucose toxicity. So, you know, when the blood sugars are high, the pancreas just shuts down. And so I'll say, we're never going to get, you're going to be frustrated, we're never going to get where you want unless we break through that glucose toxicity. And you may not be on insulin the rest of your life, but if we do insulin early, it's much less likely you're going to be on insulin. So what we see is in these glucose toxic patients, if, and we've got, you know, many examples from our own clinic where, you know, someone did the, you know, start metformin, 3 months later, come back, they're high, maybe you titrate up the metformin, 3 or 6 months later, maybe add a sulfonylurea, before you know it, you know, a year and a half's gone by, and within 2 years, that patient's on insulin dependent forever. And then you got a patient that comes in with the same A1C, you know, 10 or 11, you put that patient on insulin from the get-go, and 5 years later, they're still on metformin because you got rid of that glucose toxicity. And so that's the discussion I'm having with them is, if you don't get rid of it early on, you're going to be on insulin permanently, and things are much harder. Remember that it's not just about insulin, you've got these GI hormones and glucagon and the liver and the pancreas all talking, and if that's all shot, they're much more brittle. It's going to be hard for them. But if you can keep them off multiple injections for longer, their life is better.
I don't know if we're thinking about the same 19-year-old guy who somebody put him on metformin, and he came to us like a month and a half later, and he dropped his A1C from like the report of 13, it was like way down, and he was just like, I don't know if we're talking about the same guy.
Well, I've seen some patients like that, because some of them are like drinking soda 5 times a day. I mean, big, 16 ounces, and you know, you're just doing some of that, cutting
Yeah.
a major change.
They're drinking a huge amount of calories, yeah.
And the brain doesn't know. When you drink sugar, your brain doesn't know you're getting calories. Your brain doesn't catch that somehow.
So you and I don't care how they get to goal, we just want them to get to goal. So that's the point. If they can get to goal by cutting out the sodas and you put them on, I put them on at least a sulfonylurea, and that works, and then maybe 6 months later they're even off the sulfonylurea and they're doing the metformin and maybe some DPP-4 or GLP-1, I'm fine with that. What you don't want to do is to leave them there for 6 or 12 months, and then you start adding insulin, and it's a horrible downward spiral. The other thing I think we really need to tell our patients who do you know, get the fear of God, and this happened to my brother-in-law. He had an A1C, he had a fasting glucose of 140 and high I don't remember what it was. He had pre-diabetes range sugars and high triglycerides, very high triglycerides, coronary disease in the family. Primary care doctor talked to him about his triglycerides and metabolic syndrome. I don't think they ever used the word pre-diabetes. He didn't hear it if they did. So he did a great diet. He's a very, you know, worked out, got everything normal. What they didn't hear is you need regular follow-up. And he works out of his house, doesn't need to see the doctor very often. 3 years went by and his A1C was 8.3 next time he was checked. Because he did really good for about a year or two, and then as we all do, the diet relaxed a little bit, the exercise went down. So I'm really telling these folks who turn their life around in the short term, you have to get checked every 6 months. You cannot go away from the doctor for 3 years because you'll come back and have diabetes, you know. And he was never offered metformin, that was the other thing. So when he came back with this diagnosis of diabetes, we couldn't, you know, that he was offered lifestyle versus metformin. I strongly recommended that he take metformin. He started checking his sugars twice a day. He was checking after meals, and these, you know, a lot of people do these juicing things, right? So he could see what things he could put in his juice that raised his sugar, what ones were okay. And so he got a lot of information. He was only on metformin out of doing his finger sticks, and he took it to heart. And so that was a case where it saved him money doing the check. Okay. Other questions about that? All right. This one is just an insulin-resistant patient. This is a 49-year-old woman. She's had diabetes for a long time, 15 more years. Novolog mix twice a day, 100 units twice a day, and metformin. Oops. Okay, anyway, she's on more than 200 units of insulin a day and metformin. What do you want to do with her? She's on the mixed insulin, the syringe doesn't go any bigger. So.
Does she have a dog to walk?
Or
She
two.
needs
Talk
to
my
walk a
dog.
dog.
Let's all go to the
walk
shop.
him.
Keep a volunteer.
The dog always wants to walk. The dog likes you.
That's a great idea. Her weight,
Yeah, that's right.
she had A1C of 12, she eats 3 meals a day, never has a low, average almost 300, but she does go down to 86 every now and then if she doesn't eat something. Her weight trend over 8 years, she started at 223, lost weight down to 164, she's gaining again. So there's a couple options. You could do, you could add a GLP-1 agonist, or you could change her to U500 insulin. Actually did both of those things. I think I did the GLP-1 agonist first and didn't get anywhere, and then I changed her to U500. So the way you do it's Humulin R U500 concentrated insulin. It's made by Eli Lilly. It is 5 times concentrated. So in the syringe, all the insulins we use, Lantus, Novolog, they're all U100. They have 100 units per ml. This one has 500 units per ml. So it's very concentrated, and they love it because instead of having to drop that whole syringe, and sometimes our patients are taking 100 of Lantus twice a day and 60 or 70 of Humalog 3 times a day, and they've got 5 shots in huge volumes. You just give them 2 or 3 shots a day of a small volume, and it makes their life a lot easier. The other thing is, if they can get some control of their sugars, that gives them a little hope. Because sometimes if you're giving them a whole 100 units of insulin and it doesn't do anything, you just think, well, why even bother? I'll just eat whatever I want because nothing's going to help. So they start seeing some control, and that can help them. So the way you do it is you take their total daily insulin dose, divide by 5. If they eat 3 meals a day, so that'd be 40 units. If they eat 3 meals a day, I'd divide it 3 times a day. If they eat 2 meals, I divide it BID. And this one is slow to act because it's regular insulin, so you have to get it 30 minutes before meals. So this particular patient, I gave it before breakfast and supper. We have the pharmaceutical rep has brought cards that say I'm on U500 insulin. When you write the prescription, you have to say it's not really 40 units, it's 200. So I'll say draw up to 40 unit marker on U100 insulin syringe, the equivalent of 200 units or whatever, or I'll say I'll write it, draw up to 20 unit marker on U100 syringe, the equivalent of 100 units of insulin. And so I'm very clear. The other thing you have to be very careful about, I tell the patients that they get sloppy with U100 when they're so resistant. So I had a guy that was on U500 and he ran out of it for a week. When he got it back, he did what he used to do in the olden days, which is you take a whole syringe full. So he took 100 units, which took 500 units of insulin at once. Called the nurse and told her what he did, and we went, oh, he was fine. He never even got hypoglycemic. But you don't want that to happen. So I say you cannot do that. It's 5 times concentrated. You have to stick to the rules. You can't just make up doses and give them. So be very careful. The potential for hypoglycemia is great. The other thing I don't do is I'm very reluctant to use this in patients who are in nursing homes and stuff. I did it one time and I educated everybody and still he had a medication error. So it's probably not safe to use if you don't have people that know what they're doing. And I educate them when you go in the hospital, they may switch you, and that's usually where errors happen is they go in the hospital and somebody doesn't know what they're on and they either switch them back to U100 and then send them out and they go back to U500 on U100 doses and it's all a mistake. So we have, usually specialists should do this, but just know it's available. And we can, you know, do the education and the startup and then send them back to you if we need to. Okay. So that is kind of the end of insulin. And I know this is short, but hopefully you know where to go to get information. So we're just going to run quickly through when do you need to send a patient to the emergency department. I mean, a lot of times they call in and we say, well, we think you should go to the ER with this sickness. But what if they're physically in front of you? What do you need to do? We've already talked about hyperglycemia. If they have ketones, if they're not keeping down PO, if they have any of those red flag signs, anybody with acute loss of vision. So if they say, yeah, I can't see out of this eye, they go to the ER. They could have a retinal detachment or ischemic neuropathy or something that needs to be handled right away. Diabetic foot, if they have no pulse in the feet. It's cyanotic if they have a cellulitis more than just a very minimal thing. If they have wet gangrene, they need to go to the ER. Hypoglycemia, what about that one? Hypoglycemia if they have any of the alarm symptoms. So altered mental status. Now sometimes they have altered mental status, but you treat them and it goes away right away, you know. They don't have to all go to the ER, but if they have out of proportion or scary altered mental status, they don't wake up the way you think they should, they need to go. Chest pain, shortness of breath, vomiting and hypoglycemia, focal neurologic changes, fever, abdominal pain, infection. If they're on the sulfonylurea, especially if they're elevated and they have low blood sugar, remember that's going to hang around with them for hours or potentially even days, depending on the sulfonylurea. Like I said, I've seen people with congestive heart failure and renal insufficiency been in ICU for 4 days on D10 drips with glyburide. So you're not going to treat that in the clinic and send it home. It's got to go to the hospital. Now the emergency protocol, though, is if they have glucose in the low range and symptoms that are mild without altered level of consciousness, you're going to give them 15 grams of glucose and repeat blood glucose in 15 minutes. Well, 15 grams, repeat it 15 minutes. Administer until they get to a safe range. Follow up with a protein snack. So we usually give them either juice or glucose tabs or gel at the get-go, and then if they got to drive home, we're giving them some peanut butter crackers for the before they get in the car, that kind of thing, because it could drop again, right? And again, it depends on, are they hypoglycemic because they took, my favorite thing, they take their full dose of insulin and then eat hardly anything so they'll look good for you, right? So then you've got, and often when their sugar is 80 in the clinic, it's perfect, but they sit in the clinic for an hour and a half, I'll say, well, how much insulin did you take? What did you eat? Oh, it's 80 and you didn't eat anything and you took 15 of Mulan? Okay, here's some crackers, And we're going to check you before you go, by the way. And so you have to think about what the context, how much insulin did they take and why are they low? Is 15 grams going to be enough or are you going to have to do something else? Now, if the glucose is less than 45 or they have altered mental status, then you're starting with a bigger, heftier dose, 30 grams. And I like to use the gel if they have altered mental status, if they have kind of a little bit, rather than the glucose tablets. I don't want the tablets to get stuck in their trachea. Or you can give the glucagon, and obviously if they're looking scary, you're going to call 911, because if the glucose or glucagon doesn't work, they can put in an IV.
Can I ask you?
Yeah.
You use the glucagon, how much is that going to bump their glucose up?
It'll usually go a lot. Like, they get that hormonal rebound when you give glucagon and stuff. So usually if you have, given them glucagon, they may well go over 200. But it's a short-lived thing, and I never chase hormonal rebounds with insulin. That's something I teach them. If your blood sugar, if you treated yourself right now, if you went to 400 after your hypoglycemic episode because you drank a 42-ounce big gulp, you know, then you can use some insulin. But if you did 15 grams and you still went to 300, it's just a hormonal thing. It'll go away pretty quickly. So I'm usually trying to not to chase those. And it depends on if it's hormonal rebound or how much glucose they took. So one glucose tab is 4 grams, so it takes 4 glucose tabs to treat mild hypoglycemia. And I think that the gels, most of them are 15 in one gel. You can squeeze gel under the tongue, but if you don't have, say that they're not swallowing very well, and you don't have glucagon, you'd want to use glucagon in that patient, but if you don't have it, you can squeeze gel in their buccal mucosa and they can get some of that absorbed. You don't want to obviously put anything down that's going to cause them to. And glucagon will make them throw up often, so if they get glucagon, make sure they're not laying on their back, you know, roll them over. The other thing
The
about,
second rule
yeah.
there applies, obviously, call 911.
Yeah.
We don't have glucose tablets here in the clinic, right?
We do. We do have glucose tablets and snacks.
Do we have the gel?
You have the gel?
We don't have the gel.
Where do you guys, do you have it upstairs,
I
downstairs?
have the tabs upstairs.
It should be in the crash.
Liz has some
It's in the
there.
crash.
Yeah, Liz has some
Crash
downstairs.
But we should make sure
that
we
is
have
a
the gel.
We don't, it's just,
And in our drawers.
Yeah, I think the gel is in the crash cart.
Because,
That's where I've seen the gel before.
Yeah, I was asking because usually when I think to get, loads on my patients and we kind of need to find, snacks and stuff, so
Yeah,
they
we
have a
have
hard
some
time.
with cola and the glass.
I have used that before
I've
when
used
we
it
ran
before.
out of our juice.
Mhm.
Yeah, the lab
Liquid Coke.
Cola. You
Give
take
half a
whatever you can
bottle.
get.
Yeah, we kind of exactly, I start looking for juice, so, whatever I can find around the clinic.
Should we have
It's in the
glucagon on the crash cart, do you think?
We, yes, we
Yeah,
have
I'm not sure that
glucagon.
we do.
We should have it in the clinic, yes.
We have.
On the crash cart, we should have.
Yeah, but what,
You know,
this,
the ambulance often will use the D50 things too, and I used to keep those in the minor emergency center where I worked, and they're not that hard to use if you need them.
The problem with D50 is it's
Gotta have a
very,
vein.
if you don't have a vein, it will, it can cause a compartment syndrome if it extravagates into the, yeah. So you really need to, you never push D50 into a hep block, you need to have a dripping IV to make sure that it's patent. I've done that before when I was a resident, we pushed it through a hep block and it wasn't pretty. Don't do that. Okay.
Note this stuff.
Don't do that. It was in the hand and that was not good. Okay, I don't think we need, just to show you that diabetes self-management and medical nutrition education, by the ADA or the American Association of Diabetes Educators, there's several modules that you have to go through: healthy eating, monitoring, taking medications, problem solving like sick days or what to do when your sugar's high or low, healthy coping, that's talking about stress and depression and reducing risks. So your patients really need to be figuring out how to get them all that comprehensive education, and some of it we used to do through group visits. Most of it's being done one-on-one now. Sometimes they can call. We're looking at getting videos that we're going to share where patients can watch in the waiting room. We have some in English and Spanish for use next door, and I'll get those to you guys. But one thing we really need to do is, as you guys discover things that aren't working or questions you have about the protocol, ask your team, and we'll, if we need to get you information on 340B pricing or whatever, we'll do that. Tell us what you need. We know that we have to improve the efficiency of our EMR, so when you have things that are just wasting your time, let us know, because really and truly there's a lot of, in the CCC, there's a lot of effort being put toward making our electronic medical records work for us instead of, being a monkey on our back, and so we can tell them we've got to have this happen. Yours is a little bit smaller, but the CCC is looking to help the whole safety net, and that encompasses you. So I think that we can ask for things like that. So if you notice, things that improve your efficiency, let us know. We have to increase our capacity so we can see more patients, and that's why the protocol helps. It helps us if we don't have to think about everything in great detail, we can move a little bit faster. We want to engage our community at different levels and start using, other folks to help us be creative. And, my interest is in studying outcomes like which diabetes education works better or what drugs, work better in our population. Because honestly, there's a whole new arm of the NIH, well, it's not an NIH, it's called the PCORI grants, and they're grants. So we used to do the NIH grants where everything had to be randomized and controlled and done in a special way, and that didn't really apply to the community and our population very well. So there's a whole new division that was created in the Affordable Care Act to do research in settings like this, where you use real world settings, real patients. You don't have to set in such strict controls, but you're comparing outcomes of different things. So I'm hoping that we will be involved in that kind of research to guide us so we can have a better diabetes program here in the real world. So I think that this rapid transformation in the protocols are going to help us. I think that we have to address diabetes in a comprehensive community approach, not as single providers. And you all were talking about walking the dog, getting that physical activity in, getting people memberships at the Y. These are the ways that we're really going to help with our patients, not just throwing drugs out, and we understand that. So give us feedback about what's not working so we can make it better.
Something I found out, Medicare will pay for gym memberships. Certain forms of Medicare will pay for it.
That's fabulous.
Yeah.
And I'm always saying, you can buy a lot of gym memberships for the money you're spending on drugs.
Well, it's good to know that Medicare understands that.
They won't pay for vitamin D levels though, unless you.
Or dogs.
I diagnosed a lot of people with bone pain.
We're tired. We got about 10 minutes if we want. Do you want to run through the foot exam real quick, or do you want to ask questions? How do you want to spend the time? I can do this in 5 minutes if you want.
Let's run through the foot exam.
You have to use the tuning fork every time.
Let's run through the foot exam.
All right, let's run through it then. And I will try to convince you that I think the tuning thing fork is a good idea, but we'll see if you like it. Okay. So what is the comprehensive diabetic foot exam? Well, first of all, I don't care about data. I care about preventing diabetic foot ulcers. That's why we do the comprehensive. We want to identify high-risk feet to prevent those ulcers. The lifetime risk of an ulcer in our patient is as much as 1 in 4, 25%. And they have about a 5% risk of amputation if they get an ulcer. So that's a lot of patients. They're getting a lot of toes and feet cut off. They have almost a 50% risk of a contralateral amputation. If they have one leg cut off, 50-50 chance of getting that other one cut off. So we can prevent that. These ulcers cost our system $9 to $13 billion annually, in addition to other diabetes costs, just foot ulcers. That's a recent article from Diabetes Care, so they're expensive. So I relied on this comprehensive foot examination risk assessment and task force from the ADA, endorsed by the American Association. So this was where I came up with this recommendation, and it also mirrors what's in the 2014 ADA guidelines. So this is what they suggest. Using a 10-gram monofilament, yes, the tuning fork, our friend the tuning fork is there. Don't forget good lighting. Having the patient have their feet elevated helps you out a lot. Otherwise, sometimes you have to examine them in the chair, right? You're almost down on the floor, lifting those feet up, trying to see. I had a patient not too long ago that had a crack in her toe. I completely missed it. She said, yeah, you missed that crack in my toe. There was a lot of blood. So I had to look again, and yes, there's a crack there, but if you don't lift those toes up, you might not see it. And sometimes you need gloves if their feet are soiled or if they have an open wound. Don't forget to ask them if they've had any problems. If you're just looking at the feet and you don't ask, you might not know. Did they have an ulcer in the past? Is anything hurting? Check between their toes. Do they have tinea? Do they have fissures, cracks, deformities? Check for pulses. Posterior tibial and dorsalis pedis. conduct them on a filament, and check their vibratory sensation. So the first step is just looking. Do they have deformities that are going to rub on the shoe and cause a callus? Claw toes are very common. When patients get neuropathy and their nerves to their muscles and their feet don't work, that often results in the claw toes. Do they have bunions? Those are the places. Do they have that Charcot feet? Those are the ones where sort of the center of the foot collapses and it kind of looks like a rocker bottom and they get things there. Then you're going to feel those pulses on the back of the foot and behind the ankle bone on the medial side. So a normal exam is no deformities, no calluses, no breaks in the skin. You feel all 4 pulses. Then you're going to do the filament exam. The proper way to do it is you hold the filament at 90 degrees. You depress it so it bends. It takes about a second, and then you release it. Then you're going to touch. I touch all these toes, and then I touch 3 places there. So I always do the little toe too, because sometimes patients will just miss that one. I had a patient who felt all the touches in every toe except one big toe, and he was a vendor at South by Southwest. 6 months later, that toe was cut off because he wore some shoes, stood on his feet for 12 hours, got an ulcer, and it never healed. And so normal is they feel every touch. If they miss one and it's reproducible. Now sometimes you can tell you're doing it, they're not really paying attention, their mind's wandering, and then they start saying yes, yes. So if it's reproducible though, it's abnormal. And then the tuning fork, you're going to hit it hard so it clangs, that 128, the big one, the little one is for hearing, this one's the big one. And you're going to hold it at the base of the big toe. And you got a clock in the room, you're going to count, watch 12 seconds or count in your head, 1001, 1002, 1000, a little slower than that. But normal is 12 seconds or greater. This one correlates with balance, and that's what is so helpful, because and it's also a thing that you can look at over time. So let's say a lot of patients have normal monofilament, sometimes they don't even feel the tuning fork. This is an objective way where they can see diabetes is harming their body, and they know they better do something about it. They've already got neuropathy. So it's something objective, they can see the damage happening. And then the other thing is, if they don't feel that tuning fork, they're at great risk for falls, and you'll talk to them. Say, you stub your toe at night. Do you fall when you're stepping down off a curb? You'll see they'll get ankle injuries because they twist their ankle when they're stepping wrong. So I'll educate them about fall risk reduction and importance of having night lights and all the things you do. So patients who are at greatest risk for this are our tall patients because their nerves are so long. So my patients with worse neuropathy, some of them have great control of their sugar. They're just 6'5" men that have had diabetes for many years. And their nerves, there's a long way. So normal again, inspection, no calluses, deformities, breaks, all 4 pulses are present, all touches are felt, and vibratory greater than 12.
Do you look at capillary refill? I always look at capillary refill.
I do that too, because that's microvascular disease sometimes too. So yes, and I look at that in context. So if I have a patient who has great pulses, but their skin is shiny and fragile and they have no hair on their toes, and they might not have great microcirculation, and they don't need a femoral bypass or anything, but they're at risk for an ulcer, and especially if they have loss of protective sensations. So loss of pulses though, peripheral artery disease is one of the higher things. So they have no risk if everything's normal. Risk category 1 is loss of protective sensation with or without a deformity. Risk category 2 is peripheral vascular disease with or without loss of protective sensation, and then risk 3 is history of a previous ulcer. So the higher the risk, the more you're going to watch them. If you've got patients in any of these categories, I'm probably looking at their feet at every visit. Now, if I've seen them just a week ago, I might not be, but I probably am. But if a young, healthy type 1 diabetic with normal circulation, normal sensation, I don't think I need to see their feet every time. I won't make them take their shoes off. But if they have these feet, I do every time. And you only need to do this exam once a year. I do it twice a year. I'm a specialist. I hold myself to a little higher standard, but for that, because patient, and then I'm showing them if they're losing. Diabetic shoes, MAP pays for diabetic shoes. They have to go to Applied Orthotics, and your nurses will order those. You can just refer them, right? So just task it to Evelyn or Liz. Yeah, she'll order them for you. The procedure is they go there, they get measured, and they get imprints or whatever for the custom things. And then they will come back on another day and get their shoes.
And is that for any risk foot, like?
And they have to have, MAP won't pay for them if they have nothing.
But
However,
any risk, like
any risk they
category
will.
1 or
Yes.
1, 2, 3?
And what I do, honestly, MAP is much more forgiving than Medicare. So I can get MAP to pay for a shoe if I say they have pain in their feet. You know, I'll make a big deal about painful walking and all that kind of stuff, and MAP will cover it, central health. But if Medicare won't pay unless they have specific things, and they include deformities with preulcerative callus, poor circulation, loss of protective sensation, and your note has to include that ICD-9 code, and you have to fax it to the company. It's very restrictive.
Yeah, they started denying those, recently.
What's
Before
the code that you have to have?
I'll have them in the, usually I check them off for you because I review the records and check them off.
It's basically for circulatory disease, and you have to document a preulcerative callus, a previous history of an ulcer. Now, what's a preulcerative callus, you know? Looks like a preulcerative callus to me. But it has to be documented. It has to be documented. It can't be. I have one lady that is on dialysis, and she has the most normal, beautiful foot exam. And I always feel bad telling her she can't have diabetic shoes, so I actually got her diabetic shoes. Don't tell Medicare. I'll be in prison. Okay, oh, these are the diagnoses, Rich, and they're in your, okay. So peripheral neuropathy, callus formation, ulcer, deformity, that's a nice one. Partial examination, poor circulation. Okay, that's it. So,
That would include bunion
How
deformity.
type of
there you go, bunion counts, because it works like that. Now, the other thing that I tell patients is be very careful when you get new shoes. I have seen so many toes gone after new shoes. You know, what happened to your toe? Well, I wore new shoes to a funeral for 8 hours and walked on them. Well, I stood on my feet. Well, but they were such pretty shoes.
This is women you're talking about.
And you you get new shoes, you wear them 1 hour in the house. Take
She's
them off,
pointing in our
put your
direction.
feet. So I tell 3 days, you break your shoes in at least over 3 days, only 1 hour, take them off, inspect your feet, feel them for blisters. If they're okay, do it the second day, do it the third day, and then you can wear them.
No shoes shaped like this.
No. Yes, I will send that PowerPoint to you, the footwear.
I'd like to nominate Dr. Dubois for a round of applause. Thank you so much.
Yeah, thank you, Susan. That was really great. And I also want to thank Evelyn, who helped coordinate the stuff together.
Dana, nice to see your face again.
Yeah, hi. And actually, for all of you guys, we're meeting with Dr. Appel and Mary